Right. All right, so we are back. This is Senate Health and Welfare, still April 17th. And we're picking up some additional testimony on 6/11 from the department. And Alex, you're here. Is Alicia also here? Oh, I have to divide it.
Good morning.
Good morning, Alicia. Thank you for being here. The process we've been talking about, the prior authorization piece.
So each of us will be speaking to a different amendment this morning. Alicia will start us off on the prior authorization piece, and then I will speak on the HIB amendment. So I'll pass it to Alicia to start.
Okay, second of that. And Jen, did you want to say anything before this? All right, so let's.
Wonderful. Good morning. For the record, Alicia Cooper. I'm the Director of Managed Care Operations for the Department of Vermont Health Access. I'm here to offer some comments on the proposed language that was discussed earlier this week regarding a continuation of the prior authorization waiver that had been implemented as part of the Vermont Medicaid Next Generation ACO program. I'll start with a little bit of background for anyone who may not be familiar. In 2017, when DVA implemented the Vermont Medicaid Next Generation ACO program as part of our contract with OneCare Vermont, the program included a waiver of Medicaid prior authorization requirements as part of that ACO contract. Under this arrangement, providers did not have to seek prior authorizations for any Medicaid members who were attributed to the ACO for services that were part of the ACO's total cost of care or their financial accountability. This prior authorization waiver was in effect from when the VMNG program started in 2017 through when it concluded at the end of 2025 and was a very popular feature of the Medicaid ACO program. The PA waiver also provided DVA with a lot of valuable data to inform some of the changes that we have been able to make to our prior authorization requirements more holistically as the Medicaid program. And so currently, the main categories of Medicaid services that still require prior authorization are out-of-state services, services that are high cost, for example, genetic testing services, or areas where we have greater potential for fraud, waste, or abuse, like durable medical equipment and supplies. So with that as background information, I would like to share two primary concerns that we have with the proposed amendment. But if there are any questions on the background, I'm happy to pause here first.
This one, please send it in your testimony.
Yes, thank you. So the first concern that we have with the proposed amendment, which would continue the prior authorization waiver from the ACO program, is that the ACO model and the hospital global budget model, which we are now implementing, are very different with regard to the shared financial accountability framework. Under the ACO model, Medicaid was comfortable waiving the prior authorization requirements for certain services because both we as the payer and the providers who are participating in the ACO arrangement were sharing in that financial accountability for the total cost of care, regardless of where it was being provided. Under the hospital global budget methodology, the shared financial accountability is more limited to those services that are specifically happening within a hospital organization. Since many of the services that Medicaid requires prior authorization for are either high cost or are occurring out of state, or not with those hospital organizations that are participating in the global budget model, a prior authorization waiver that continued would be less likely to directly impact the hospitals in the global budget model and would affect services that were happening elsewhere.
It's one to clarify, question. Talking about out of state, so you're aware and some of our healthcare networks are do have people that regularly go through say dark, and so forth. And so does this exclude them or include them or?
Yes, I would be happy to share some specific materials from our documentation. We do have less stringent authorization requirements for those facilities that are sort of on the border of the state or where we know we have a lot of Medicaid utilization to our Vermont Medicaid population. So the out-of-state services that I'm primarily thinking of are the complex specialty services where someone might need to go to Boston or New York or somewhere that's further outside of our sort of regular patterns of use for our Medicaid vendors. The second concern that we have with this proposed continuation of the prior authorization waiver is more technical. It has to do with how the PA waiver was implemented in our system. And it was implemented based on the ACO model, which had attribution. We had specific Medicaid members who were attributed to the ACO, and we were able to implement the prior authorization waiver by asking our system to look for claims for those specific Medicaid members. In our hospital global budget model, we don't have an attribution framework, meaning that a hospital that's participating in hospital global budgets will have that hospital global budget model for any Medicaid member that comes to them at any point during the year. There's no specific list of members that are attributed. And so when we established the PA waiver for the ACO program based on attribution to the ACO program, we had to build it into our claims processing system. And in order to do something for hospital global budgets, we would have to build something different into our claims processing system.
Are you saying that not all Medicaid patients were part of the ACO?
Yes.
How many were not?
I can get specific numbers from the most recent year. It was a relatively small proportion that were not, but primarily members who were not having Medicaid as their primary payer were not attributed to the ACO. So anyone who was a dual eligible or anyone who had other sources of insurance coverage is not attributed through the Medicaid ACO program, but their claims are considered part of the hospital global budget methodology. So those are the two reasons that we have concerns with this proposed language. And for those reasons, we do not recommend including the proposed amendment.
But it's questions for Alicia. So really, your concern is about the administration. That's interesting.
It's that from a technical standpoint, I don't know what it would take to be able to operationalize it. And from a policy perspective, I think we don't have the same shared financial accountability. So the financial risk of waiving those prior authorizations would be mostly on the Medicaid program.
It's actually
It's not, I think we're adding, the question is like, should we add this?
right on. Got it.
For slight traffic.
Yeah. So do not add the message.
It sounds like you're really supportive of this.
I will say, and I had a chat with Devin earlier this week. I think we're very interested in looking at our Medicaid prior authorization requirements for the full Medicaid population, rather than thinking about it in this concept of a waiver of prior authorizations that would be specific to either certain providers or certain pockets of our membership.
That kind of fits with our beliefs or just about everything.
Yeah. Seems like a good idea.
Thank you. So Devin, did you want to go?
Sure, I'm happy to.
But before we get to you, Alex is on the screen with information of roughly that.
Of course, if you'd like me to go, or if Devin wants to go and talk about the waiver amendment, that's fine too, if you want to
Yeah.
group them that way.
Okay, let's do that. Do you have something to say?
Devin Green, Vermont Association of Hospitals and Health Systems, and I appreciate the testimony from David today. As I mentioned earlier, we needed to understand the operational policy and sort of unintended consequences that this may have. And I think for now, we will pull this proposal, and we're happy to do that. And we're also happy to work with Diva in the future. They've done a lot of work on prior authorizations, and we'll continue to work with them to bring down the administrative burden for hospitals and patients.
Okay, thank you for that. If there's anything you think we should include in the bill that will keep this moving along, us.
Alex. Okay, Alex, we are ready for this.
Hi, good morning, everyone. Thank you, Chair Lyons and members of the committee. For the record, my name is Alex McCracken. I'm the Director of Communications and Legislative Affairs for the Department of Vermont Health Access, and I use she, her pronouns. Thank you for the opportunity to testify today regarding the proposed amendment to H611 on HIV medication coverage. This language would require insurers, including Medicaid, to provide additional coverage for HIV prevention and treatment medication with no cost sharing. Respectfully, the Department of Vermont Health Access would request, if the committee wishes to move forward with this amendment, that the language be changed to exclude Medicaid. There are a number of reasons for the department's position. Vermont Medicaid already covers a brand or generic formulation of every available PrEP and PEP medication without prior authorization, including long-acting injectables. Many HIV treatment drugs are covered and available without prior authorization or step therapy. Additionally, HIV PrEP drugs do not carry a copay for Vermont Medicaid members. It is important to also reinforce that this change would result in a significant fiscal impact. DVHA is working to determine the estimated cost, but this impact is due in part to the increased utilization, but largely due to the loss of DVHA's ability to manage the class for the lowest net cost to Medicaid, which allows us to capitalize on rebates. The way that DVHA Pharmacy currently manages this class of medication allows Vermont Medicaid to collect supplemental rebates. Medicaid, as you know, has a duty to provide quality care in a fiscally responsible way. Currently, this category is brought to DVHA's Drug Utilization Review Board, or DURB, for review a minimum of every 2 years and typically more frequently than that. Additionally, it is worth noting in the context of increased federal interest in and scrutiny of Medicaid program integrity across the country, that HIV medications are often a target for Medicaid fraud, in part due to the high reimbursement amounts. DVHA is also concerned that the inclusion of this language in our technical housekeeping bill could jeopardize the movement of H611 through the legislative process. This amendment would require a stop in appropriations that would otherwise be unnecessary, and we want to ensure that the important elements in sections 1 through 9 of this bill, such as Medicaid coverage for doula services, burial fund eligibility limits, and reducing administrative burden on DVHA staff, do not get delayed in a fiscal detour. Finally, as other witnesses have noted, the current proposed language regarding providers' authority to prescribe and dispense these medications is problematic. This language is simply not workable for DVHA as written, as CMS requires all providers to be enrolled with Medicaid. It is the position and recommendation of the department that if the committee wishes to move forward with this amendment, Medicaid be excluded from the language. DVHA can be open to a report on fiscal impact and a continuation of this discussion during the 2027 session.
Thank you.
Thank you.
And will you send us your written testimony?
Of course.
Senator Benson,
Just a question, Alex, have you sent us some suggested language or cross-outs?
We can provide suggested language, absolutely.
Yeah.
Thank you. Thank you.
Thank you so
Alex.
much.
Appreciate that. That is helpful. We have
that's it.
That's it.
We covered ground this morning.
All right.
So thank you all for being here, and we're gonna call it a wrap today.